Thank you so much for joining me.
Yeah, no, fantastic. I'm really glad to be here. Thank you.
You're in Australia. So do you want
Mhm.
to just start by explaining a little bit about your background, maybe a little bit about how you got into the whole realm of sleep in the beginning?
Yeah, well, it was about 12 years ago. It was my husband snoring. It was really bothering me. And I'm so frustrated one evening, I decided to get up and look about the dental sleep appliances. I knew that these were an option for obstructive sleep apnea and snoring. And
You
so
were
I
already a dentist at this point.
That's correct. Yes, yes. So
Right.
as a dentist, yeah, so I am a dentist and I wanted to learn more about those dental appliances because it's not something we're taught in dental school.
Right.
And I actually enrolled in a graduate diploma in dental sleep medicine. So for 2 years, learning more about sleep medicine and how to become involved with it and work with sleep physicians. And I started to realize that snoring is not just a sound, but it is linked to increased health risk and how detrimental it can be for people. And I became more involved in offering these sleep appliances. So they really are a compensation to actually band-aid to deal with a jaw deficiency, basically.
Right.
And so I was starting to wonder, how come we can't deal with the underlying deficiency when children are young? We're taught that in dental school. You can do early interceptive orthodontics for children when they're 7 to 8 years old. How come we're just watching and waiting a lot of the time and we're taking out teeth when children have stopped growing around the age of 12, doing braces? Why can't we deal with this underlying problem early? And so that's really
Mhm.
why I wrote the book, to kind of help people understand what are the benefits of early intervention for breathing and for sleep. And
Mhm.
the more I looked into it, the more I started to realize that we can even do a lot of work much, much earlier on in childhood, because
Yeah.
the way the jaws are formed is influenced by how the muscles are working from infancy.
Yeah.
Yeah.
So we're going to get all into that.
Yeah.
And I think for a lot of people, they're taking their kids to, I was going to say the pediatric dentist, but their pediatrician as well.
Mhm.
And they're kind of saying there's some things going on with sleep and what can we do? And a lot of them are told we just need to kind of wait and see what happens. And can you maybe speak a little bit to how urgent it is for parents to get involved a bit earlier and really advocate for their kids?
Yeah, for sure. Sleep is really critical in the earliest years of life. We know that the brain development, 90% of the adult sized brain is attained by the age of 3 years. And this is when we need sleep the most. And so we know that as important as it is to have the right number of hours of sleep, we need to be making sure the quality of sleep is good. And typically, parents are pretty happy if their child is sleeping through the night. They're not necessarily checking on their child's breathing, but there are things to look out for, whether it be mouth breathing, snoring, restlessness, tossing and turning, neck hyperextension, and many more that could indicate a child is not breathing really well. When that doesn't occur, a child is going to be more at risk of problems like difficulties with emotional regulation, poor attention and concentration, symptoms of ADHD. When children are not getting restful sleep, they're not tending to be like adults, where we might get more sluggish. They may be more hyperactive or need to move, inability to sit still
Yeah.
and have tantrums and things like that. So I think it's really important that we address these issues when children's brain function really requires that sleep.
Do you want to explain a little bit about how jaws are developing, like from the moment kids are born and kind of what's happening with that?
Yeah. So the first year of life is the most rapid period of jaw development. That's when the jaws are growing the most. And one of the biggest environmental influences of jaw development is how are the muscles working. And so we want to promote nasal breathing from the earliest years of life. And we want to look out for ensuring that babies can sleep with their mouth closed, their lips sealed. So sometimes it's as simple as just helping them to close their lips. But the other thing that's really important is the feeding. We want to make sure a lot of parents, they recognize that breastfeeding has many benefits, immunological and health benefits, but not really well promoted is the mechanical benefits of breastfeeding. Because for
Hmm.
breastfeeding, we need to have good tongue suction, where the tongue is elevating to the roof of the mouth and suctioning against the hard palate. And then as it drops, it creates a vacuum, and that's how milk is extracted. really efficiently.
Mm-hmm.
And so we want to let parents understand that the way we feed our children in that first year of life is also going to influence how the jaws grow. And we want to stimulate the muscles as much as possible through breastfeeding. And sometimes, yeah, like you mentioned, tongue ties, they can be a barrier to getting good effective breastfeeding because they don't allow the tongue to suction really well. And a lot of the time people have these problems and it's very overlooked because we're not really taught how to identify tongue ties or recognize those
And
symptoms.
I think people, just having been through, breastfeeding two kids, I think that there's not really enough support for breastfeeding mothers, and a lot of people will struggle on for a long time when they're having things wrong with the latch and clicking noises and just stuff that's not going well. And I guess some support to kind of know what effective breastfeeding looks like would be really helpful for a lot of women.
Yeah, for sure. We there even to see a lactation consultant. Many parents aren't familiar with what a lactation consultant does. But even when we see a lactation consultant, there's a difference in the knowledge of tongue ties as well. So that's really important to recognize. So it's not unusual to see people that have seen multiple different professionals that have been told there is no tongue tie, and they're put on all different medications and told different things, shields, and told babies will grow out of the situation.
Yeah.
So I think it is important for mothers to follow their gut when something is wrong and seek out different opinions.
One of the really interesting things that you wrote in your book, there's a lot of mothers who are told by, healthcare professionals, but they'll just kind of like look at the baby and say, oh, that tongue tie is not a problem, but it's really to do with the function, right? Of what the tongue can do and what's restricted from doing because of the tongue tie.
Yeah, I think it's really important to pay attention to the symptoms and recognize that it is really important to have good tongue elevation. It's the tongue elevation that is really critical for good milk transfer, for good swallowing, even later on for good articulation and good breathing and good tone that we need for good palate development and sleep. And another common thing that occurs with these tongue ties is the misdiagnosis of reflux and colic, because babies cannot lift their tongue and swallow correctly and they're taking in lots of air. And so I see that a lot in practice where babies are so unsettled, they're given these medications which are not proven at all. And no one has really inquired about the latch or how much air are they taking in. So I think that's a really important thing to look for as well.
So as far as encouraging better jaw development in kids so they can grow up super healthy and not develop sleep apnea, we hope, what things, as you mentioned, like keeping the mouth closed and nasal breathing, and what are the other things? So chewing on hard things?
Yeah, for sure. Chewing, we know that is really important to stimulate the jaws. And so the muscles, because so we want to also avoid dummies because what they do, so pretty much for the tongue,
Pacifiers for people in America.
So I think for the upper jaw, the palate, which is really the template, good palate development is the template for good lower development. We really want to focus on good tongue function. And so that includes nasal breathing, because when we close our mouth and we have that tongue resting in the roof of the mouth, that tongue is going to broaden or sculpt that palate. And nasal breathing is important because that's where we spend all our time, the majority of the day. So that light, persistent force of that tongue up against the roof of the mouth is going to mold the palate. But then we also need to think about breastfeeding, as I mentioned, and also pacifier use, which lowers the tongue. So it lowers the tongue, and then
so pacifier use of any kind. Is there a particular one that's better, or no? Just you think none?
Anything that lowers the tongue is going to interfere with that tongue position, and it introduces increased sucking pressures or inward pressures that distort the palate. Because that jaw is so malleable in the first year of life, it has an influence. And those impacts are related to intensity, duration, and frequency. So obviously, the least we do it, the less impactful it will be.
Yeah.
But a lot of people might say, oh, I just use it for sleep. However, sleep is the time where babies spend the most time. And
Yep.
so it's just about educating people. And there are some babies that will rely upon it, but sometimes when babies rely upon it, there may be an underlying issue. And I do think a lot of babies that do require it, there is an underlying issue that
Yeah,
should be
I think with the thumb sucking as well, like there's a dentist I recently interviewed, Jill Umbrello, but I was a really serious thumb sucker for years
Mhm.
and years and years, and Jill was saying, well, that's your way of trying to bring the soft tissue out of your airway to breathe better. Because and also like, I think something to do with your vagus nerve or something, like if you've got your thumb at the roof of your mouth. So that was kind of interesting to me. I never really thought of it that way. But so thumb sucking and finger sucking aren't great either.
Yeah, I think sucking habits are a compensation, and usually I'm starting to think that it's a reflection of poor tongue function. And there is some research from Italy which suggests that having the tongue in the roof of the mouth, it really needs to sit and hit that N spot where we say N,
Mm,
because that area has the highest concentration of sensory receptors. And when that tongue touches that spot and stimulates those receptors, it sends signals to the brain, and it's involved with neurotransmission. So it turns on pathways that release dopamine and serotonin and other feel-good hormones. And so when the tongue isn't on that spot, these type of sucking habits can also be a compensation to stimulate those receptors. And so I think there is that neurotransmission aspect that we're missing. And it's a way for people to feel good when they put their thumb
yeah.
on that spot. And so it's really common to, I think a lot of people in the myofunctional therapy space will agree that when we have children that are older and they really want to stop sucking their thumb and we've got them on board, it's very predictable to get them to eliminate that thumb sucking habit within 24 hours if we're teaching them where to put their tongue.
Right. You had some questions that parents, like if parents are listening to this and thinking there's something going on with my child's sleep and I need to find a dentist just like you, but they don't live near
Mhm.
you, there was a list that you had of the kind of questions people can ask. This is kind of a new developing area,
Mhm.
and the
Mhm.
training among dentists and pediatricians is vastly different. So you're going to go to some dentists who really won't know a lot of this about facial and airway development.
I think it's really important if you're seeing a dentist that they should understand that teeth grinding is actually a key red flag that a child might not be breathing well. Because a lot of the time in dental school, we're taught it's something that they'll grow out of.
Yeah.
And so if they can understand that it is breathing related often, then that's a pretty good clue of someone that might have done some further learning. And then we want to ask them, do they refer to orthodontists for early intervention, and how early do they go? Because if they're involved with early treatment before the age of 7 to 8, they may understand that there's functional reasons for breathing and sleep that we might want to do early treatment. Or do they refer to a myofunctional therapist to address?
I think this is one of the things that it's really important to get across is, treating these kind of issues with children really involves a team, right? It's not about just going to one person usually. It's like sometimes you'll then get referred to myofunctional therapy, or you'll go to an ENT or whoever it happens to be. So people should definitely expect that, right?
Yeah, absolutely.
Oh yeah. So about the age that you can start working on kids. Like I think at one point in the book you talked about, it might have been Dr. Gamo, I can't remember, but they were saying like if you're waiting until the 7 or 8, which is kind of like considered early orthodontics in the mainstream, they're saying that's too late because so much of jaw development happens earlier than that. So what kind of age are we really trying to find somebody to help us with this, like especially as far as palate expansion goes?
Yeah, well, Dr. Christian Gimeno, he actually says that 60% of jaw development is done before the age of 6. And so we really need to be addressing that poor development in those early 6 years of life. And so I've started to offer expansion in children around 4 years old. I've got 3.5-year-olds as well. And that's about the earliest age that I can get really good cooperation and get them on board to do it.
Yeah.
But there are practitioners that are doing it from the age of 2 years when children have all their baby teeth. It's a good time where we have something to anchor or support those appliances.
Mm-hmm. And do you want to explain? I always assume a lot of knowledge, but let's go back and explain
Yeah.
what the palate has to do with nasal breathing and whether kids can sleep well because of what's going on with their palate. Do you want to explain all that?
Yeah, absolutely. So with the palate or the roof of the mouth is actually the floor of the nose. So when we have a narrow palate or any dental crowding, which indicates that the jaw is not growing well, what that means is we're going to have some degree of limitation of nasal airflow. And so we have research to support that when we do palate expansion, even a few millimeters increase in the width allows exponential increases in the nasal cross section, which means air can flow more easily. So that's one aspect of it. The other thing is that it is also the housing for the tongue. And so we want good tongue to palate seal for really good airway stability to keep the airway open. And so when we open up the palate, it makes more room for the tongue as well. And so when we look at adult obstructive sleep apnea, what we know now is that typically in the past, a lot of focus was given to the mandibular advancement devices that bring the lower jaw forward. However, a lot of the time when we have retruded lower jaw, it is accompanied by some degree of constriction of the upper jaw. Yeah. And so the upper jaw is really key to actually get everything working. So, I've had your journey and it's so much more difficult and more invasive. And I just think it's really important for people to recognize this. We can actually modify and mold it a lot more early.
Yeah. That's one of the things I care most about is just if I can share my story. So so much went wrong in my early years that I can hopefully a lot of the stuff that now as a 45-year-old, this stuff is really difficult, right? It involves kind of surgeries. And I think that actually figuring it out early with young children hopefully we'll have a whole generation that don't grow up to develop, sleep apnea as an adult. But so talk to me a little bit about adults. Do you actually treat adults anymore, or you mainly are just treating kids?
I do see adults.
Okay.
A lot of the time they may come in for a tongue tie consult. Yeah. And they may have sleep and breathing problems.
I thought the section in your book where you're talking about some case studies of adults was super interesting. But so it seems as though if people are wanting to try and address this underlying issue of having a very narrow palate and, constricted airflow in their nasal airway and all that, then it seems like you're suggesting people look at surgically assisted dome. Do you want to explain what dome is? And just do you kind of do that before you would suggest people do MMA surgery?
Yeah, I think surgery, it sometimes can be a very good intervention for people. Right. A lot of the CPAP and the dental devices, they're really Band-Aid solutions. They only work at nighttime. Right. And the ultimate goal should be to restore nasal breathing. Right. And sometimes that means developing that palate. And traditionally, we thought that the suture closures, you can't do that for adults. But now we know that you can use these mini implants or little screws that are placed in the bone next to the mid-palate suture. And what that means is you can put a little screw mechanism that applies the force directly against the palate, directly across the palate suture, so we can actually get that sutural stimulate separation rather than move the teeth. And sometimes it may involve a bit of surgery, like the dome technique, which is really just releasing some of the other sutures to allow the bones to move more easily. previously they used to do a big cut in the middle of the
Yeah.
palate, and then at the back as well, just to allow things to move more easily.
Yeah.
But those mini implants, like the MFC, it actually allows that force to be placed very directly across the suture, so it can be moved
Ah,
easily and often can be done without surgery. Other things like the appliances and the acrylic appliances and different things, they may not get that same sutural expansion,
right.
and they may tend to move the teeth more, which can kind of tip the teeth, and
Yeah.
sometimes it's really not appropriate for people. Some people that are less severe, they may benefit from that improved tongue space. But really, at the end of the day, if we want to improve nasal breathing, using predictable techniques involving mini implants can be a good option.
On
We
the
do have very
person.
limited options for adults, but
Yeah.
I do in our city. But I do believe that palate expansion plays a very central role. If we can make sure
Yeah.
that people's palates grow, it's really important for nasal breathing, really important for the tongue space, and for the whole support of that upper airway or throat.
You explained in the book really well about how restrictions in nasal breathing, it almost causes like a vacuum and makes it more likely that things are going to collapse.
Yeah, for sure. A lot of the time, adult sleep apnea, the roots are in mouth breathing. And so if you try to breathe or snore with your mouth open versus snore with your mouth closed, you will notice that when you close your mouth, it is less likely that you're going to snore, because as that tongue is up and sealed against the roof of the mouth, air just flows really well and smoothly through the nose and down the back of the throat. But the moment that the tongue is down, mouth is open and the tongue is down, and we've lost that tongue to palate seal, air has more than one way to flow, and we have to breathe a little bit harder. And that's when we're going to get those instability of the airway and increased risk of collapse. The more and more I see adults snoring in obstructive sleep apnea patients, the more I'm recognizing that we really need to address this mouth breathing problem. And a lot of the time when I see people that have had obstructive sleep apnea and they're here for dental devices, they've had various nasal surgeries that haven't worked out. And so we know from the team, Dr. Stanley Liu and the team at Stanford, they have established that people that have failed nasal surgeries, the common link is a narrow nasal floor or a narrow palate.
Oh, I know what I wanted you to explain as well, is you have a really
Yeah.
good diagram in the book where you're talking about the continuum from open mouth breathing and snoring right through to severe sleep apnea. I think that a lot of times people think, like especially in our current system, I'm sure it's similar in Australia where people are going for a sleep test and they're told, even though they have a bunch of apnea events, they're told, "Oh, your AHI is really low, we're not gonna do anything to treat this."
Well, obstructive sleep apnea is the end stage problem, and it's a very arbitrary definition. You need to have for adults, 5 obstructions, 10 seconds or more every single hour of sleep on average. But what people don't recognize is that that those numbers, 9 seconds, if you have 9-second obstruction, it's not counted.
Right.
How low is the oxygen dropping during that time? And I want people to recognize that if we look on the other end, these problems begin when mouth breathing starts. And even mouth breathing in children, we know that it's linked to a significant increased risk of behavioral and learning problems and ADHD-like symptoms. And then even if we have we may work harder to breathe, so we may not necessarily have 10-second obstructions. The sympathetic nervous system is more alert and it's in fight or flight mode. Every time it looks like the airway is collapsing, there's an arousal from sleep and increased stress response, or things like teeth grinding to kind of keep the airway open, and it protects against sleep apnea or those longer obstructions. But that leads to very fragmented sleep. And so in children, it's linked to all those problems. But then the other group that's underdiagnosed or recognized is young women, premenopausal women. They are tending to get more of the upper airway resistance syndrome, where they're constantly in fight or flight mode. But that's linked to a lot of other problems like anxiety, irritable bowel, fibromyalgia, all these other functional somatic syndromes where there's an increased response to stimuli, and it can be linked to this chronic stress of not getting good night's sleep. So I do think that it is important that we look beyond the AHI and obstructive sleep apnea and try to achieve healthy breathing.
Okay, tell people where they can find you.
Where they can find me,
Yeah.
probably my website.
Yeah.
drshereenlim.com.au, or
Okay.
I'm probably the most active on Facebook. So I'm
Okay,
often
right on.
posting different cases and information there.
Thank you so much for your time.
No, thank you so much. Thank you for what you do as well. I think really it's that adult problems that are often the most despairing, because we know, gosh, we could have actually resolved or achieved a different pathway.
Yeah.
And so I really appreciate the opportunity to talk to you today.